I think the telling question that I've come to recognize is most important is not really asking people what have they done, but it's more a question of what's going on. What's going on with you in terms of pain? What's going on with you in terms of your life? And so my case history would include the sort of standard biomedical, biomechanical questions to rule out that there's particularly any sign of any underlying pathology, but would very quickly move into how the pain and the injury has impacted on the individual and how it's impacted on their life or interfered with their life.
FC2O. From chaos to order. From chaos to order. Here we go. From chaos to order. From chaos to order. FC2O.
This week, we're joined by Dr. Nick Penney, who has some incredible results in working with people experiencing persistent pain, which I know is a hot topic both in professional circles and has been voted as the leading topic people want to hear about here on FC2O. Now, Nick originally trained at the British School of Osteopathy here in London in the UK, then went on to do his PhD at the University of Queensland in Australia, where he investigated the biopsychosocial model, specifically looking at obstacles to recovery. Nick came to realise that you can't separate out the mind from the body. You have to consider both and help patients and people understand how the mind and body talk to each other. Nick went on to train in and to practice mindfulness, getting both first-hand experience and expert insight into how mindfulness can help people to transform themselves. Nick began to integrate an understanding of neuroplasticity, or how the brain can rewire itself, the influence of epigenetics, or how our genes can be switched on or off by our lifestyle choices and thoughts, and the bidirectional communication between body and mind into his clinical work. Nick found that attention can often be hijacked by pain or distressing thoughts, and that mindfulness training helps us understand that we can have a choice on both what we pay attention to and what meaning we give it. The purpose of mindful medicine, therefore, is to help you understand that we have this choice and how to be aware of it and to engage it. So join Nick and me as we travel through Nick's journey to help more people move from a life of pain to a life of meaning and happiness. Enjoy the show. Here we go.
So welcome to another edition of FC2O with me, Matt Wallden, and my guest today, Dr. Nick Penney. Hi, Nick. How are you doing?
Very well, thank you, Matt. How are you?
Excellent. Yes, very good, very good. It's quite early here, so I've got my espresso with me, so hopefully that will fire things up. And you might need something to keep you awake at your end, because where are you based?
Based in Auckland, in New Zealand. So currently we are about 11 or 12 hours in front of you. I'm not exactly sure.
Yes, something like that. Yeah, pretty much polar opposites anyway. So
Yep.
Yeah. So Nick, I know that you trained originally as an osteopath, and so can you explain your sort of career trajectory, where you started, and obviously your most we'll get through to your most recent research and the way you're practicing now. So
Sure. So I originally trained, as you say, as an osteopath at the British School of Osteopathy in London, and next year will be the 40th year of our year group graduating. Wow. We graduated in 1980. And I started my practicing career as an osteopath with Kim Burton, who was an osteopath in Huddersfield in West Yorkshire, who very rapidly transited into ergonomics and research. And for the first 9 years or so of my career, I practiced with Kim and on my own account as an osteopath in Skipton in North Yorkshire.
Right.
One of my early associate osteopaths once remarked to our receptionist when she was told that she would be seeing one of my patients that she really hated seeing my patients because she never knew where to start And when the receptionist asked, "Why is that?" and she said, "Well, I really don't know what he does. I think he kind of talks them better."
Right.
And that was the thing that turned out to be quite true with my later career. So I left the UK in 1989 and came to New Zealand. At the time, I was almost in transit to join the osteopathic school at the Royal Melbourne Institute of Technology in Victoria, but I washed up in New Zealand, and it took me another 10 years to get to Australia.
Right.
Practiced as an osteopath in New Zealand, but was also head of the osteopathic association in those days, as we were seeking statutory regulation for osteopaths, much as occurred in the UK.
Yeah.
And as a result of that, being a stakeholder, we were involved with the first clinical practice evidence-based guidelines for the management of acute low back pain. So back pain that's been present for 3 months or less.
Yes.
And this was the point at which my early associates' prophecy came to pass, when I started to become aware of what are called the psychosocial factors, which are things that prevent people from necessarily recovering from acute low back pain. And New Zealand was the first country in the world to produce guidelines that included the assessment of these factors: stress, distress, anxiety, and depression. Seemingly a long way away from the sort of basic osteopathic model, but something which I clearly observed a lot in my patients over the years.
Yes. Yeah.
And as the guidelines were produced, it was clear that lots of people didn't really understand what was involved. And I got very interested in this and the work of Professor Gordon Waddell some years ago.
Yes.
And that led me to leave New Zealand to pursue a PhD, a doctorate in musculoskeletal medicine, specializing in this biopsychosocial approach to pain, which I completed in 2009 at the University of Queensland.
Okay. So yes.
So that's probably the potted history of my career. I continued to work as an osteopath during the time of my studies, and then relocated back to New Zealand, where I've been practicing more in terms of pain and specializing in pain, and running a multidisciplinary integrative practice to help people better understand and manage pain.
Right. Fantastic. So I know this is probably a very, very difficult question, or impossible question to answer, perhaps. But what would your normal process be with a patient? And I guess the reason I prefaced it with it being tricky is that, of course, it's going to vary patient to patient. But presumably, there's some kind of loose thread that you go through in terms of an outline when someone comes in with, let's say, with a persistent pain issue.
Sure.
Yeah.
Maybe the slight difference between what I do now and what I used to do was that as osteopaths, we work more in terms of primary care, taking people off the street, getting referrals, people self-referring. In the pain medicine world where I work now, our patients are all referred.
Right.
So they come with a history attached to their case. But I think the telling question that I've come to recognize is most important is not really asking people what have they done, but it's more a question of what's going on.
Yeah.
What's going on with you in terms of pain? What's going on with you in terms of your life? And so my case history would include the sort of standard biomedical, biomechanical questions to rule out that there's particularly any sign of any underlying pathology, but would very quickly move into how the pain and the injury has impacted on the individual and how it's impacted on their life or interfered with their life.
Right. And so this is reflecting that kind of biopsychosocial view. So you're interested in the the biology, as you say, but also in particular the impact on their sense of well-being, their sense of self, and how that affects their relationships as well. Is that kind of
Absolutely. Well, it covers a multitude of things. We know that pain and depression are basically two sides of the same coin.
Mm-hmm.
So when people come with pain that's persisted, more than 3 months or so, then it's already starting to show its impact on their mental health and their mood.
Right.
It's very often aggravating, perhaps underlying anxieties, and as well as all the anxiety that's generated by the pain and what people fear they might have done, and how they fear for their future.
Yeah, and so when people come in with this persistent pain issue, you have a sense that there's likely to be these kind of comorbidities that are psychological in nature, and so then where do you go with it from there? So you want to know about what's going on for them in their lives, and that's a kind of very open question, presumably, that allows them to really talk about what's foremost. Yeah,
it allows them to talk about what's important to them. What's my story, and often people don't get much of a chance. And it's one of the things I've always enjoyed about osteopathic medicine is that we have the luxury of time to be able to sit down and allow people's stories and histories to gently unfold, rather than being time pressured into saying, so what's the primary symptom and let's deal with that, rather than dealing with the person behind the symptom. As Sir William Osler, who died almost 100 years ago, and once said, a good physician treats the disease, a great physician treats the patient who has the disease.
Yes.
And I think that's very pertinent to what we do.
Yeah, and I think, didn't Hippocrates say something along the same lines, or at least he was attributed or credited with saying something about treat the person that has the disease, not the disease that has the person, something like that.
Yes,
yeah,
absolutely. And I think AT still said something along the same lines. These things always have a thread, all the way through them. But I just like the idea that what's going on is really allowing people to broaden out all the areas of their health and their well-being that may be a concern to them, and also allows us as clinicians the opportunity to gently explore things that the patient may not realize are impacting on their ability to recover.
Yes, for sure. So do you have any examples of or hypothetical cases where someone comes in with this persistent pain? Let's say it's low back pain, because that's obviously a very, very common one. That perhaps have got a little bit of comorbidity in terms of some depression. Where would you go with that? Obviously, they're going to tell you what's important to them. What's the next step as far as you're concerned?
Figure out how much the pain is interfering with their life. So pain interference, you can classify, or is defined as a way of measuring how much the pain impacts on people's cognitive abilities, their abilities to think, their emotions, their physical activities, which include sleep and enjoyment of life. So we may often see, instead of just asking somebody to rate how much something hurts from 0 to 10, an average patient may say, well, it's the pain severity is maybe 4 or 5 out of 10. If you ask them how much it bothers them, then the answer can often be, well, 8 or 9 out of 10.
Right.
It's impacting a lot on me and my life, which of course is why they're seeking to try and do something about it in the first place.
Right.
I don't see depression or anxiety or diabetes or any other kind of diagnosis in terms of a medical comorbidity, in inverted commas. These are all part of the patient's life experience.
Yes.
So how does all of this fit together? Is their diabetes well controlled, for instance?
Yeah.
and we use screening measures to help us assess if people are clinically depressed, are they aware of that?
Mm-hmm.
Often people are. And then, well, how's this being addressed?
Yeah.
What's the evidence behind managing depression? Are they getting enough exercise? Are they getting enough sleep? If they've been prescribed antidepressants, are they taking them?
Yeah.
Are they engaged in talking therapies? It's about looking with a broad-angled lens to sift out the factors that may be pertinent to this individual person. If you take an example of actually neck pain, there was a study done some years ago of women in the workplace suffering with neck conditions.
Yeah.
And the researchers looked to find what was the single biggest factor that predicted women being off work with neck pain. And everybody sort of jumped at the thought that maybe it's sitting in front of computers, sitting too much, and came out with a whole raft of different things. And the answer turned out to be the biggest predictive factor of a woman having time off work with neck pain was an unsupportive management style at work.
Oh, wow. Wow. Isn't that fascinating?
So something out of left field that nobody, in a sort of a standard clinical assessment, nobody would think to ask about, how do you enjoy your job?
Yes.
How long have you been there? How well supported do you feel and valid in what you do?
Yeah.
And it's surprising then how that will then potentially open up a conversation.
Yeah, that's fascinating, isn't it? I just recently did an interview with Bronnie Lennox-Thompson, who, of course, I'm sure you'll be aware of, and is an occupational therapist. And so, talking about occupation, not just in terms of jobs, but in terms of, what people are actually occupying themselves with. It was a fascinating conversation about how important that is, and her whole concept of living well with pain.
Absolutely.
Yeah. And I saw that. So I saw that you've got several videos on your site, which are great. They're nice short videos, so people can just sort of get bite-sized chunks of your experience and wisdom. And one of those videos was your 6 A's approach, and I saw a few connections there between what you were expressing and what Bronnie was expressing on her podcast with me. But so would you be willing to go through that 6 A's approach, starting with the apprenticeship? A.
Now you are really going to test my memory, because I can't say I've looked at that in some considerable time.
That's why I said starting with apprenticeship. So okay, let me just run through the list. So it's apprenticeship, application, attention, awareness, acceptance, which of course is the maybe think of Bronnie.
It's a big thing.
Yeah, and then action as well.
Right.
So when you say apprenticeship, what are you kind of pointing to there?
Learning about pain education, really about understanding pain as a sign of threat, not necessarily as a sign of damage.
Yes. Yeah.
So as an apprentice, we're really just learning the ropes and learning a different way of looking at these things that trouble us in our lives. Pain science has moved on a long way from the idea that damage is necessary in order for us to experience pain.
Yeah. And what's your experience with patients that are there? They're in pain in front of you, and you explain to them that pain doesn't necessarily correlate with damage. Do they sit there in disbelief? Some of them, or are they quite open to it?
I think it comes as quite a surprise to a number of people. But it allows the consultation to move to this idea that hurting doesn't necessarily mean people are harming themselves.
Yeah.
So one of the big factors in preventing people recovering is fear of pain and fear of movement or re-injury. So if people can come to understand that hurt doesn't mean harm, then that also then allows you to help them recognize that movement may be something that is therapeutic and helpful to them. With some people, this takes time, and there's a deal of patience that can be necessary.
Okay.
In order to help people shift, the beliefs about pain that they've been brought up with, And of course, the difficulty with that is it's very easy for them to go and seek another opinion where somebody will tell them that it's all about the damage that they can see on their X-ray or their MRI scan.
Yeah, that's a really important point. I think probably most of us that are online should have an awareness of that. But that's this idea of having a nocedic effect through the language that we use and the sort of ideas that we put in patients' heads.
Yeah, absolutely. Research done at the George Institute in Sydney concluded that really we should be very careful who we're offering scans to. Because once you've put up a picture, it's a very difficult image for somebody's head to get around. That may be a complete red herring.
Yeah.
And also that people who are subjected to MRI scans are more likely to be offered invasive techniques, surgery or injections for, say, low back pain. And their evidence actually showed that far from reassuring somebody by taking a scan, you often actually put their pain score up a little by taking a scan and then demonstrating the wear and tear that we can see in everybody over the age of 18.
Right. Yeah. Fascinating, isn't it? And I suppose
it is.
Yeah. Well, one of the things that I've come across in discussions in the past, because I think migrating from that more biomechanical view of the body into this awareness of greater awareness of pain science, pain neuroscience, and so on. One of the papers I've been aware of for many years was this paper by Booz et al., which was from 1995, and it was showing that in that particular paper they found 76% of asymptomatic people had disc injuries. And it was a very good
demonstrable bulges in the intervertebral discs. Yeah,
that's it. Yeah. Do you know the study? Have you seen it?
Yes, I do.
Yeah. Great. And so what I had used that study to explain when I was training, sometimes osteopaths, but quite often fitness professionals as well, is to say, well, look, if we know that 3/4 of the people that are coming in have these disc bulges, irrespective of pain, or with no history of pain, then we just need to be careful with our technique. And it makes sense that we should teach people optimized lifting technique and all this kind of thing. But this is kind of quite counter to the way the whole pain neuroscience field has moved. And they've used that figure actually to say, well, not so much that there's danger in those 76% of people that have these disc bulges, but more that actually it's a normal thing and most people can get by without any pain in spite of the disc bulges or demonstrable damage. Yeah. So, I mean, this is something that obviously, I imagine you've had to work with people that have a degree of knowledge. They've read around it and they've heard that these disc bulges cause problems, or that, as you say, the scans show these bulges. And what I was thinking was an interesting sort of crossover with some of your other work is that these ideas are quite powerful, aren't they? So they're really mind. You could say they're mind viruses or memes.
Yeah.
And so, how do you have any techniques specifically to work with that, or is it just a case of education?
It depends on some of the other factors. If somebody is very high in what's known as pain catastrophizing, pain catastrophizing being the more we freak out about the pain, the more it hurts, really. We know that people who are high in pain catastrophizing, and Sullivan in the 90s produced what's called the pain catastrophizing scale, which we use as part of our battery of outcome questionnaires. If you have somebody high in pain catastrophizing doesn't respond to simple education and reassurance.
Right.
So you have to do something fundamentally different to be able to alter that pattern of behavior, that belief.
Yes, yeah.
And so that then brings in the idea that somehow we have to have some other tools to be able to work with. And you mentioned acceptance, which is obviously something that we work a lot with, and we work a lot in my practice with mindfulness-based cognitive therapy and mindfulness-based stress reduction. And the the basis of these practices is learning to pay attention to our actual experience,
Yeah.
not the story that my mind tells me about my experience, which is what usually catches all of us,
Right. Right.
and not the negative emotion that then therefore comes from the story rather than the experience.
Yes. Yes. Okay.
When you can teach people enough mindfulness skills to be able to do this, then they're able to disengage from those catastrophic thoughts.
Mm-hmm.
There are lots of little techniques, and one of the simplest sort of take-home ones that we can use today is taking a single thought, like my back's damaged. That's what the scan says. So we sit there and we ask somebody to close their eyes and sit there and just allow that thought to percolate around in their mind. They're not trying to do anything with it, but I'm just sitting there for about 10 cycles of breath with the thought that my back is damaged. After that minute or 10 breath cycles, we ask people to prefix my back is damaged with I'm having the thought that my back is damaged.
Yeah.
And we let them sit with that for a minute. And then finally, the third minute is other prefix. I notice I'm having the thought my back is damaged.
Yes. Yes.
And by doing that, and I've done it in quite large groups in various presentations, we start to put a little distance between the thought that my back is damaged, and by the time I'm having the thought that my back is damaged, there's now a bit of a question in my mind. Is my back damaged, or is it just a thought?
Yes. Yes. That's a fantastic, very simple drill, isn't it? It's really good.
It's a simple drill. It's known as a diffusion technique from acceptance commitment therapy, which is really just a way of trying to see that my thoughts are thoughts. They're not necessarily facts. They're thoughts. They're mental events, and they've perhaps been put in there by a well-meaning clinician who hasn't understood that I'm quite fearful about the idea that my back's damaged because my father's back was damaged and he ended up having surgery and was never quite the same again.
Yeah. Very interesting.
For instance,
yeah. When I was doing, I don't know if you know much about my background, but I did the osteopathic training and then did some training with the Czech Institute and went through their whole sort of gamut of training from 2001 to 2005. And the last level of the training is quite a lot about people's beliefs. And we had a guy come in who's a sports psychologist more than anything, but he did a half day with us, and he gave this. I think it's a fairly standard kind of concept, but it's the idea that you're sat watching your life play out on the stage, and you're totally engaged in it. You're in the front row, totally drawn into this situation that's unfolding on the stage, and it might be a painful situation, could be physically painful, emotionally painful, etc. And he says, but then what I want you to do is so he kind of takes you into this relaxed state, and you're looking at something that's been very stressful for you, and he asks you just to step up, just to stand up and to go up to the back row and to look down on yourself, watching yourself on the stage. So you're kind of, so you've disembodied, essentially. You've got up to the back row, you're looking down.
Absolutely.
And it strikes me that's a very similar kind of concept to what you were just...
it is. It's another diffusion technique, and it is designed to put some distance between my experience and my perception of my experience.
Yes.
So and there are 101 examples of them, and they are quite effective.
Yeah.
The other thing is, if you have a very troublesome thought or emotion, you can identify it and sing it to yourself, probably under your breath, to the tune of Happy Birthday for a minute.
Right, yes.
It's very hard not to end up laughing at yourself.
Yeah, I bet.
When you take this painful thought or emotion, or if you can do a Donald Duck voice in your mind, you do it in a Donald Duck voice, and it just provides enough separation for us to disengage, which is all we're after.
Fantastic. Yeah. Now, okay, so we started on this 6A's process. So went apprenticeship application is the second part of that 6A's process, which I think we started to talk
about. If you've got knowledge, you have to be able to apply it.
Yeah, and so examples of that, obviously, that drill we just talked about, the diffusion drill is an example of applying that knowledge. But what other examples would you give?
Well, if you take the hurt isn't harm example, then we'll often find out to people what their capacity is. Well, I can walk for 20 minutes, but if I walk for 20 minutes, my back's really getting quite sore. Okay, so we're not doing any harm here, but what say if we're getting sore at 20 minutes, what if we walk for 15 minutes?
Yeah.
So we get close to the point where our structure might be starting to complain, or we might be building up with pain. And then we're starting to retrain the nervous system that in fact we're safe to move within this capacity. So having understood that pain is a sign of threat, the application is, can I now start to train my system that I'm safe to move, that I'm safe to stretch? And in fact, pain towards the end of, say, a range of movement might be a sign of safety. It might not be a sign of danger at all. Might be the body saying, this is enough.
Yes, right. Yeah. Yep. Yeah, fascinating. Okay. And so then attention is the next one. And I guess, is that really just about being present and not being distracted?
It is, but it's surprisingly difficult to do. So attention is really, yes, paying attention, but learning how to pay attention without the mind telling me the story about what it is I'm paying attention to.
Yes. So this whole thing about the story again. Yeah. Because I noticed on one of the videos on your site, you had, I think it was a kind of form of mindfulness where you're taking the individual down to their feet. I think it's the first video actually on your site.
Yes, it is.
And so obviously, just take a few deep breaths and then focusing attention into the feet. Again, just really being present and holding the attention there, and then recognizing that perhaps they've spent a few moments not thinking about their pain. And I thought that was an interesting, because of course there's attention, but it's attention on something other than the pain or other than the story.
Correct. Yeah. Yes, but it's not only, it's focused attention, it's by choice.
Yes, okay.
So we have a network of neurons in our brain cells called the salience network.
Okay.
And this is now what we used to call the neuromatrix, so a pain neuromatrix. Well, salience means the brain figuring out what it is I've got to pay attention to.
Right.
And most of that is done automatically. But at the point that I choose to pay attention to my feet, I've now consciously taken over my salience network and said, I don't care what else is on the cards as to what you think we should be paying attention to. At the moment, we're just going to pay attention to our feet. Us as the salience network, but what about that thought about what's going to happen tomorrow? Yes, I can observe that, but I'm going to bring my attention back to my feet.
Yeah.
What about that pain in my right knee? Yep, I'm aware of that, but I'm actually just focusing my attention on my feet.
Right.
Changing the way the system reports the information to us.
Yes, yeah. And do you ever get people that would say, but what if I'm supposed to be paying attention to the pain? Because isn't there that sort of potential? Of course, a lot of pain, people experiencing pain will have high levels of anxiety, quite naturally. And, if you're saying to them, essentially ignore the pain, focus on something else, which I know is a bit of a clumsy way and perhaps non-technical way of saying it, but
no, it's pretty close actually. But what I tend to do is I put it the other way, which is, well, is it helpful?
Yes, yeah.
Is paying attention to the pain helpful? Pain is designed to grab our attention.
Yeah.
If I am talking, to you in the kitchen and we're deep in conversation and I put my hand down on the hot plate that had only just been turned off, the pain will immediately disrupt my train of thought and the conversation with you, and I will remove my hand and curse and swear.
Yeah.
And so there's the protective element of pain. That's something I need to pay attention to, because if I don't, I'm going to incur more damage in my body.
Yes.
And that will always override at the point that it needs to.
Right. Yeah.
So one of the things that we learned many years ago with pain is that the brain does have the capacity to shut pain down to zero if at the point we're feeling pain, the pain is likely to stop us being able to survive.
Yes.
So this is primarily in sort of warfare and highly traumatic situations. You know, people talk about being in horrendous accidents and not being aware that they'd really injured themselves.
Yes, exactly, yeah.
Because at that point, when a threat to survival is so great, the brain has the capacity and the drugs on board, what's called the endogenous opiates, to shut the pain down to zero.
Yeah.
Later on, we're going to feel a lot of pain. So all we're doing is really trying to leverage that a little bit.
Yeah. I was going to say shark bites is an example of that, isn't it? Quite often you hear this story.
Absolutely.
That people just think something's brushed past them and then they realise half their legs missing or whatever. Yeah.
Absolutely.
Yeah. So something that you mentioned there just caught my attention, because I think you said something like pain is designed to grab our attention. And in an editorial I wrote last year for the Journal of Bodywork, that I had an image in there, and it was essentially kind of schematic of the nervous system, just really spinal cord and the reptilian sort of concept of the brain, but the idea, and I had a little finger just poking the cortex, and the idea was that the finger was representing pain, and it was saying that a lot of pain is from the unconscious processes or the automated processes of the body, just giving the cortex a nudge to say, hey, this needs some attention. I was wondering if does that kind of fit with your way of thinking to some degree?
Yeah, absolutely. I think it's designed to tell the salience network, this is potentially a threat, it needs to be paid attention to, until we can determine whether we need to fight, run away, or in fact whether there isn't such a great threat there.
Yes.
After all.
Yeah.
And the brain's remarkably good at doing it, and in fact the problem is it gets so good at doing it that it learns how to do it. So the longer we're in pain, the easier it is for the pain to be generated by the brain. The brain and spinal cord literally learns pain.
Yes.
And the longer we're in pain, the better it gets at it. So in fact, our pain levels often start to creep up.
Yes.
As the nervous system adapts.
So this is kind of the process of facilitation as described. Is it? Do you know if that? Because I forget the exact definition, but it's something along the lines of each time an impulse traverses a given set of neurons to the exclusion of others, the resistance becomes smaller on each future occasion. So something like that. Is that kind of still relatively current, would you say?
Absolutely. The more you use a circuit and a synapse, the easier it is to use it. In effect, you strengthen it.
Yeah. Well, this
so makes it very pertinent that it's important about what we pay attention to.
Well, one of the things that that struck me when I was listening to that meditation we were talking about, or mindfulness, focusing the attention into the feet, is one technique that I've used with pain patients is toe tapping, and so it's a similar kind of idea that you can lay down, so you're unloaded, you're rested, and so I guess the level of threat is perceived to be lower, but often they're still feeling pain. And then I just get them to tap their toes together. And this was just a technique I picked up from a kind of martial arts background. And the idea, again, was that it takes you out of your head because you're putting your attention into your feet. And just by gently tapping the toes together in a rhythmic way that's kind of somewhat hypnotic, then that was, what I termed, the way I described it to the patient, was that this is a distraction technique. And I kind of used it as broke down the word, so it's distraction. It's like you've got to do something different to feeling the pain.
And distraction is a valid technique, particularly for people in in really severe pain. At which point, you do anything you can that works.
Right.
It's just that by distracting, we're avoiding.
Yes.
And so avoidance is a very useful short-term strategy to us, but it's an absolutely hopeless long-term strategy.
Yes. Yeah.
So one of the difficulties in dealing with people with persistent pain is that their avoidance strategy is now no longer working.
Yes.
I've had my treatment, I've taken my drugs, I've had my acupuncture, I've tried to distract myself, but now that isn't working.
Yeah.
So it can then be very hard for people to understand that the way that they get their system to settle down
Yes.
is by actually acknowledging, and back to one of the A's, accepting
Yes. Yes.
that this is my current situation.
Yes. Exactly. Yeah. Yeah. Well, I think this.
And at the point we do that, we stop struggling with
Yeah.
it. And at the point we stop struggling with it, it starts to dissipate.
And so this I think leads nicely into the sort of paper that you sent me. Well, it was more of a report, I think, which is your let's see, it's the Epoch
Right.
collaboration, and so you essentially you sent me this paper which documents a number of different factors, but actually showing how your approach helps people that are experiencing persistent pain. Because one of the things, what triggered me to think about this was you saying that, of course, the pain, when someone's experiencing pain, it can seem to become perhaps a hopeless situation. And actually a lot of the literature out there suggests that people should just, accept the pain and live with the pain. But actually you've seen significant clinical improvements with your work. And so how do you, first of all, how do you frame that up to the patient when you are working with them?
I say something similar to what you say, that, the general view of this is teaching people to live well with pain, but I'd prefer to teach them how to live well without the pain.
Yes, okay.
And if we accept that persistent pain comes about because of what's called neuroplasticity, the nervous system's ability to rewire itself.
Yes.
It makes no logical sense that it can only rewire itself in one direction.
Yes, exactly, yeah.
If I've become and developed persistent pain over time, the consensus, the sort of standard accepted wisdom is, well, now you're stuck with it. Well, surely if we create the right environment, the nervous system will rewire itself in the opposite direction.
Exactly, yeah. So
this Epoch, the electronic persistent pain outcomes collaboration, is part of a group called the Australian Health Outcomes collaboration, which is based at Wollongong University in New South Wales in Australia, and all the pain services that provide pain management across Australia and New Zealand are signed up to this service. And the idea is it gives us some objective measures of what we're actually doing. So rather than us just going, well, Mrs. Jones seems to be feeling better and Mrs. Jones says she's feeling better, here are a range of objective outcomes. They're taken when we start with the patient, they're taken at the end of the process, and they're then taken 3 months after that as well, so we can see that the change has been sustained. And there we can see, and in fact when we at the last meeting that we had, the administrator of the New Zealand arm of this collaboration came to me and said, well, based on the latest international classification of disease definition of chronic pain, there's a high proportion of the patients leaving your service no longer meeting that definition.
Yeah, that's amazing, isn't it?
Which is fantastic, and even better that it's seen by somebody else based on the statistics that are produced. We just upload them into a database and they do the statistical analysis and they send us the statistics back. And the hope is that providers will then talk amongst themselves. Find out what's working well, find out what's not working so well, so that we can potentially improve the standard of care over time.
And just to put a bit more of a biopsychosocial spin on it, one of the comments on the report is that you noted that a third of your patients come from the highest quintile of socioeconomic disadvantage, whereas the other services that were also included in this report had only 21% of their patient population from that quintile. So,
Right.
So you've got. Can you explain that in terms of the putting a biopsychosocial view on it?
Yeah, sure. It's a good question. Pain, persistent and chronic pain, positively discriminates towards lower socioeconomic advantage.
Yes.
So the more that life is a battle and a struggle,
Yeah.
it's just great that pain also then becomes part of that struggle.
Yes. Yeah.
And so one of the things that is known worldwide is that this is a population who can be very difficult to shift their health outcomes.
Right.
They're the population who are slow to take up the message about stopping smoking. They're the population that are slow to take up the message about exercise and dietary modification, so as not to move towards high BMIs and becoming obese.
Yes.
So to take a population, to have such a high proportion of our patients from that population and still develop the results that we're getting,
Yes.
provides me with a lot of joy and hope.
Yeah.
And of course, it also is quite rewarding that we are getting to work and offer these skills and this knowledge to people who would normally not be able to access it through a fee-for-service type of arrangement, because our service is 100% funded through what's called the Accident Compensation Corporation in New Zealand, which is the local government insurer, which covers people for pain and injury as a result of personal accidents.
That's it. Yeah. I remember it. I remember it well.
Yeah.
Yes.
It's got its limitations. Yeah. We're the only country other than Norway to have such a system, but the trade-off is that you cannot sue for personal injury in New Zealand. So you are automatically covered, and treatment and wage-related compensation can be provided if you can't work.
Yes. And look, I want to just sort of try and convey to the listeners that the results that you're getting are quite, from what I can see, they're quite extraordinary. And so what I'll do is I'll put these graphs into the show notes, if you're happy for me to do that, so people can see the outcomes that you're generating. And what would you put that success down to? So go on. You're going to say something?
Well, yeah, I'll be happy for you to do it. Thank you. I think we put it down to the understanding of people from this biopsychosocial perspective. And I know it's a long word and it's bandied around, but a lot of people don't really understand what it is. And when you look at the literature, it's not something that is routinely integrated into medical care of whatever, from whatever discipline. But the evidence is clear that this works. Now, the founder of the model was an American physician called George Engel. And in 1977, he suggested that we were getting, even then, caught up with treating data.
Yes.
We're too busy treating scans and blood tests and things that were abnormal in the patient, and that clinicians should really be able to consider the psychosocial, the psychology and the social aspects of somebody's existence and the pathophysiologic variables, the biomedicine, if you like.
Yes.
A clinician should be able to do that simultaneously. And so that's what we attempt to do. So with some patients, it would be very much more a biomedical kind of approach. With others, there may be more psychosocial kind of approach. And the thing that I think we do very differently is the integration of mindfulness and acceptance commitment therapy just into the whole treatment paradigm. You posed the question to me earlier about how do I see this fitting in? Is it an add-on, or is it something different. It's all of it. It's all intertwined with it as best it can be.
Right, yeah. So sort of interwoven in the whole sort of.
It has to be interwoven. Yeah.
Okay, great. Now, one spin on what we were just talking about in terms of the lower socioeconomic advantage and how this is consistently correlated with increased propensity to develop persistent pain and so on. One thing that I've been aware of is, and I can't remember the references right at the moment, but I can probably dig them out for the show notes. Is that trend towards increased propensity to developing persistent pain? I think that's only true of industrial nations, and non-industrialized nations. I'm not sure that that's still the case. Have you seen anything on that? Because my understanding was that this is a kind of real sort of fascinating twist, because it seems that you can go to nations that have a very low GDP and a lot of poverty, perhaps people mainly working in the fields and this kind of thing, to just essentially grow their own food. And in spite of that, what we would classify as a very low socioeconomic status, the back pain instance is actually less there than it is in industrialized nations. Have you seen anything along those lines, or is that?
Yeah, I think more recent research tends to suggest that it may just be that chronic pain is very underreported in these nations. But there was a study done in Australia, and I can't think of the author's name off the top of my head, but they looked at chronic back pain amongst Aboriginal people.
Mm-hmm.
And they found that Aboriginal people, just the same as everybody else, suffered with chronic back pain, but they saw it as being part of life.
Right.
And because they saw it as being part of life, they modified their activities a little bit. Mm-hmm. And back to one of those A's, they accepted that this was their situation as it was then, but they didn't have this belief that it was going to last.
Yes, yeah.
So maybe, and it goes back to our discussion a little bit about intervention, maybe by intervening and showing people how damaged and broken we think they are, perhaps we're potentially disabling them.
Yes, exactly, yeah.
By doing that. And of course, a lot of this work has been around the idea that we've over-medicalized back pain to the nth degree, and it's become a huge industry.
Yes. So you mentioned the A's. I think I skipped past awareness. So we went apprenticeship, application, attention. I think I skipped over awareness. And is there
we did a little
is there
bit.
A clear distinction between attention and awareness? Because they sound quite similar from a linguistic perspective.
I think there is quite a distinction, because this is non-judgmental awareness. Right. So can I bring my attention into my feet? Can I notice? And I teach mindfulness to children as part of the UK's Mindfulness in Schools project as well.
Excellent.
And when you teach adolescents to put their attention into the feet, they're absolutely astounded that there is all this sensation in their feet, which they weren't aware of until they started to pay attention to it.
Yeah. Isn't that amazing?
So the point that you
dampen it down that much that because there's lots of kind of drills like this, aren't there, where you put a raisin in your mouth is a classic one, isn't it? And feel the contours on the raisin, and then slowly chew it, and all that kind of, and we just are so oblivious to so much of the potential sensory awareness that we have.
Yeah, because we're living in our heads, and we're living with the threats and the anxieties that 21st century living has brought us, and we're losing contact with what we actually feel.
Yeah.
So awareness is non-judgmental awareness. Can I notice what I'm feeling without my mind telling me the story about what it means?
Yeah. So, there's a lot of crossover. I imagine for you as a clinician, how do you find it? Because, of course, there's a lot of new age or spiritual disciplines that have talked about these kinds of things. in very similar terms. I mean, one of the things that struck me earlier is that, when I first qualified as an osteopath, I remember Caroline Miss had just brought out her book, Anatomy of the Spirit, and then she did one on sacred contracts. And I was quite intrigued by that. So I read those books and I went to see her speak.
Yeah.
And she was always talking about your biography becomes your biology. And it's kind of, that's kind of what we're saying about the story that we're telling ourselves. There's that, if we tell ourselves a story that there's issues and there's pain and so on, then we really need to rewrite that story in order that we thereby affect our biology.
Absolutely. But, if we give it oxygen and we pay attention to it, then we can believe it. There's a wonderful researcher, Lisa Feldman Barrett, who published a very good book earlier this year called How Emotions Are Made. And one of Lisa's sayings, which I like a lot, is if we change our experience today, we can change who we are tomorrow.
Yeah.
Which basically goes back to what you're just saying. We can rewrite our story because there's a lot of scientific research and thought that the brain basically is just a very predictive organ. It spends all its time predicting what my experience is going to be based on the only thing it's got, which is past experience.
Yes. Wow.
So if I change my experience today, I can view it more neutrally. It's not freaking me out. I'm not catastrophizing about it. I'm not fearful of it. Then tomorrow, the only thing that my brain can predict how I'm going to feel is based on how I felt today.
Yes.
So
I noticed in one of your papers. Sorry, do you want to?
Yeah, go on.
Well, I was just going to say,
No, that's fine.
In one of your papers, I'm trying to remember which one it was. I think it's the 2010 one that you did for the International Journal. Yeah, International Journal of Osteopathic Medicine. So, but you mentioned in there that pain is an emotion, or emotion can be. Where is it?
Yeah, it's a sensory and emotional experience.
Yes, and so I wanted to ask about this because I've looked into this in the past, and of course it makes sense that it is emotional in many ways. I think that just is logical, but at the same time, some people, when I've studied emotion and I've looked at various people's models of emotion, pain often isn't considered one of the core emotions or the primary emotions. So can you just elaborate on that a little bit?
Well, yes, it's not. It's the emotional experience is pain, suffering, if you like.
Yes.
So we will have pain as a severity of pain, and it's inevitable. We all experience pain at times in our lives. But the suffering, the emotion that comes with the pain, we talk about that as being entirely optional.
Yes.
So pain generates emotion. But it's not a primary emotion.
Right. Yes. Okay.
And again, I think Feldman Barrett's work is suggesting that maybe these so-called sort of built-in primary emotions aren't really built in at all. They're just built. So it's life experience that tends us to feel certain things in certain situations.
Yes. Yeah.
And it takes work. This is not something that's easy to necessarily change around for ourselves. It takes time and patience and persistence, but we have the potential to change that.
Yes. Excellent.
As long as we're aware of it and we're acknowledging it and we're accepting it and we're not avoiding it.
Okay.
And for some people, that's quite a challenge, and you need skilled teachers and clinicians to be able to guide you through that pathway, really.
Yes. Okay. So we've done the first four. So we've done apprenticeship, application, intention, awareness. We've also talked about acceptance. Is there anything in addition that you would want to talk about other than what we've covered?
Yeah, I think the one thing to say about acceptance is it doesn't mean being hopeless and helpless. Acceptance in this situation means accepting that this is actually my reality at the moment.
Yes.
And if I'm accepting that this is my reality, I'm not struggling with it, and I'm therefore open to the possibility that it might change.
Right. Yes.
The other thing I think to to talk about acceptance is it covers a lot of ground in lots of different ways, but there are points at which acceptance is not the right thing to do. If somebody is living in an abusive relationship,
Yes.
then acceptance of that abusive relationship clearly is not the right tool.
Yes.
So I tend to say to my my patients as best I can that we are working towards the idea of acceptance, and we don't do this early on in a process because it's too confronting. We work our way through to get to this, which is why it's down the list a little bit. And I say, whilst acceptance is really what we're after, we have to remember that there is no negotiation with terrorists.
Yes. Yeah.
So at the point, or if the pain is too much to bear, is too strong, or there is a lot of nerve root pain, a lot of pain shooting down an arm or a leg, then there is a point at which acceptance is not going to work. And at that point, we may need to step back and deal with it in a different way. We may need to look at intervention, or we may need to look at some pharmacology in order to get that pain back under control.
Yeah.
So it's not blanket acceptance.
Yeah. Okay. That's useful clarification, because I think at first glance it can seem, and this was my concern when I first heard about it, was that there's many things, as we all know, that can contribute to the pain experience from all the stuff we've discussed today. One area we haven't really discussed is nutrition so much. We've talked a bit about lifestyle, sleep, but things like even, breathing pattern, which if you look at Leon Chato's work, then of course it ties in with a lot of the work in pain neuroscience, from the perspective that the moment your anxiety level goes up, well, then so does your
autonomic nervous system
switch.
Yeah, absolutely. And very recently, the Zidan lab in San Diego, Fadel Zidan, who's a neuroscientist doing a lot of work in mindfulness research, their group showed that slow, deep breathing in the face of acute pain is actually better in terms of pain control than a single dose of morphine.
Really? Wow. That's amazing.
So clearly in experimental conditions.
Yes.
But clearly there is this inbuilt capacity to be able to deal with pain much more effectively than we have possibly been led to believe.
Yes. Well, and this actually brings up a point that I wanted to raise with you, is that, of course, you're training people in mindfulness as part of what you're doing. So for example, there's the drill on your site with the feet, which is freely available to anyone who's got an internet connection. And isn't it amazing that so many of these things that are being found to be really important in terms of optimal management of a pain experience are free? It's things like meditation or mindfulness, breathing, sleeping, those kinds of things, moving,
Absolutely.
You don't need a gym membership to move.
No.
Yeah, it's fascinating. Do you get any resistance from your patients in terms of making these kinds of lifestyle changes or bringing mindfulness into their daily lives?
I'm quite happy when people are sort of healthily skeptical.
Yes.
When we start. And with some people, we might spend a lot of time talking about the neuroscience and the education and the how this works or the why this works. Ultimately, people have to experience it. So when you start with this work, and again, Fadel's work shows that you can change people's experience with a relatively small amount of attentional training, mindfulness training. And that can be enough to get people's interest.
Yes, yeah.
And may I share a very interesting story of a patient that we're working with at the moment. It was a lady who actually lost the lower part of her left leg in an accident.
Right.
And we've just started with the process. So she gets a lot of phantom limb pain. There's pain where the limb is no longer there, and a lot of what's called phantom limb sensation.
Right.
And we did a basic relaxation exercise the other week which was that bringing the attention down into the feet, just breathing away any tension and then gradually working up the body. And afterwards, I said I had deliberately said feet, not foot,
Right.
because
Yes.
she has obviously a prosthetic
Yes.
lower leg. And she said, no, I'm really glad that you did that, because when I didn't tell you before, but I get phantom limb pain in my toes, where my toes were.
Right.
As I breathed down into it, I could feel the pain in my toes and the pain in the instep of where my foot would be.
Yeah.
And as I was instructed to breathe it away, it disappeared.
Wow.
So at that point, I thought, well, okay, we're going to make some progress here. So we were both fascinated with the idea that not only was she feeling pain in a limb that wasn't there, but when she chose to breathe it away and let it go, it disappeared.
Yeah, that's amazing, isn't it? Yeah.
Which just shows the potential strength of the work. And we've met a number of people with phantom limb pain, and it's fascinating to see that you can make changes, and because that's very much cognitive reorganization in the brain. Phantom limb pain comes from the brain struggling to understand why there's no feedback from this limb. And so by engaging in this work, you're actually changing the way that system is operating.
Yes, yeah. And would someone like that then potentially use that as an exercise themselves at home, that they would take themselves through that same meditation?
Yeah, absolutely. We provide guided narrations because it's important that people do this work for themselves pretty much day to day. The more, if we want the system to change, it's like getting fit. If we're going to do 10 bicep curls once a week, we're not going to strengthen our bicep very much.
Yeah.
If we start doing 10 bicep curls a day, then we're going to see some change.
Sure.
And we know from the neuroscience that in terms of mindfulness work, we're really looking for, an optimum 20 minutes a day as a minimum, as a bare minimum, really, of focused practice.
Yeah, okay. And is there any risk of overtraining? Like there would be in a gym? Could people become obsessed with it? Have you seen that at all, or is that not really seemingly?
It's a good question. You can't really overtrain it, but I think you can end up striving to try and create change as quickly as possible, which, yes, in that way you overtrain and, it's not going to work. And I think sometimes people will do a lot of practice without necessarily good focus.
Yes, yeah.
And Tiger Woods said many years ago that, his father had been very criticized highly for making him hit golf balls as a very small boy. And he said, but it misses one fundamental fact, is the small boy's got to want to do it.
Yes.
And focus on it, because anybody can stand there and hit golf balls, but if they're not focused, paying attention to it, they won't improve.
Yeah, for sure.
So it takes a bit of mental application in all of these, whatever these skills are that we're trying to learn.
Yeah, it's a little bit like, I know Paul Chek has a phrase where he says, repetition is the mother of skill, so long as there's skill in the repetition.
Right. Yeah, it's good. I like it.
Yeah. But no, one of the areas that I know that we've touched on, and I think that was essentially what we were just talking about, was mindfulness-based cognitive therapy. Is that what you were just describing with the lady with the phantom foot pain?
That was relaxation. Mindfulness-based
Okay.
cognitive therapy is a derivation of mindfulness-based stress reduction,
Right.
which was developed specifically to aid people with relapsing depression.
Okay.
So the research was based on people who had 3 episodes of clinical depression. They were currently in remission when they were part of the research project. But by just adapting mindfulness-based stress reduction just a little bit more to the ruminative, repetitive thoughts that people develop with clinical depression, the Teasdale and Williams were able to demonstrate that just short of 50% of the people that you train didn't relapse back into depression.
Right. Wow.
And that is better than the drugs.
Mm.
And
Yeah,
this
yeah,
is,
yeah.
once you've learnt it, you learn it and you practice it. It's self-care, it's self-help. No more treatment, no more prescriptions, no more trips to the therapist, just paying attention in this particular way.
Yeah, yeah. That's amazing. Isn't it?
And now there's a lot of research around pain. There's some very interesting research that's being done in the US to help people not over or abuse their narcotic opiate-based medication for persistent pain. And the researchers there are showing some really interesting work that by doing this, people don't get caught up in the cues that make them abuse whatever it is that they're abusing. So you teach them mindfulness, which alters a subconscious drive to take the substance. So they're unaware of the fact that you've altered this, but you see it because their consumption of the opiate decreases.
Right. Yeah, yeah.
Rocket science, I think. It's just extraordinary.
It is. And again, it kind of touches on the whole idea of the unconscious or subconscious functions, which, I know probably it's an area of contention, but I've seen figures that suggest that the percentage of cognitive function that is conscious is actually very small. It's somewhere in the
About
region
10%.
of, yeah, or less. I've heard,
or less.
So then, a lot of our habits and a lot of our ways of being and thinking and behaving seem to be just regulated unconsciously, which is, if you think about it, it's quite common sense, because if you had to think about everything that you did, it would be a huge mental drain. So there's this, I know,
and breathe and breathe
that's it.
and breathe.
That's it. Yeah.
And heartbeat. Yeah.
Yes. And I know that one figure that I saw is that the unconscious nervous system is able to process 40 million bits of information per, now would it be second or minute? I think it's per second, probably. Yeah, it must be per second, because
yeah, it is. Yeah.
And then the conscious is about 40 bits per minute.
Absolutely.
Per second. Yeah. So it's essentially about 1 million times quicker processor. So what aspects of what you're doing and your approach are working with the conscious mind, and what's working with the unconscious? And is that difficult to say?
I think it is. It's slightly difficult to say, but I think that the work of choosing to pay attention means that we're getting a glimpse of what's going on in our subconscious.
Yes.
By the way that it's making us feel or think. So the sensations that we feel, the emotions that we feel, and the thoughts that percolate out from the subconscious. So by paying attention, it gives us a window of recognizing that, as I put it, my mind's down there rummaging through the garbage again.
Yes.
And so that then I've got a choice about bringing my awareness back to a conscious level. This is what I'm going to choose to pay attention to.
Yeah.
And another thing that I teach my patients a lot is, from my own experience, is when I notice that my mind's got very caught up in negative stories, pain, whatever it might be, I close my consulting room door at work, or the bathroom door at home, because it's the only place you can get some privacy in my house, like most people, I guess.
Yeah.
And I'd say to myself out loud, all right, Nicholas, what are you thinking? Oh, I'm known as Nick, but I was always Nicholas when I was in trouble as a little boy. So, all right, Nicholas, what are you thinking? Well, I know what I'm thinking, but I need to challenge it, because it's no use telling myself not to think it, because I already am. What are you thinking? Pause. Next moment. Second question, is it helpful?
Yeah.
Well, I know the answer to that as well. That's why I'm doing it. But again, I'm now making myself aware that what I'm thinking in the context that I'm thinking it is not helpful to me. No use telling myself not to think it. So what do I do then? Well, just like we said, I close my eyes, I just drop my attention down into my feet. It's as far away from my head as I can get.
Yes.
Pay attention to the feet on the floor for maybe 30 seconds. Now I've got my attention back, because if I can feel my feet on the floor, or I can notice my breathing, I have to be in the present moment. I can't be anywhere else. So then that allows me to move on. And I think by doing this enough, it means that another of these networks called the default mode network in our brain, often called the me network, the thing that's chatting on about me and my life and what's wrong with it, and why I should have done something else with it. When we practice formally, the default mode network goes quiet. When you stop practicing, when you've become a little bit skilled at practicing, the default mode network does not come back online to the same degree as it was before we did the practice. So we practice mindfulness to become more mindful, just more aware of our present moment situation, and then that potentially, I think, decreases the drive from the subconscious, which is back to our ancestors. All our subconscious are really interested in three things, which is food, shelter, and a mate.
Yes, exactly. Yeah.
And watching for threats.
Yeah.
Well, if I'm paying attention to my present moment, maybe there isn't any threat here. And therefore there's no need for my physiology to wind up to meet a threat which is more imagined and been driven by subconscious than its actual reality.
Yeah. Fascinating. So I think we've done 5 of the 6. So the last A in your list of 6 is action. And I assume, is that fairly self-explanatory, that it's really...
It is, but I think it's a bit like we talked about focus. It's committed action.
Yes, yeah.
It's putting what we've learned into play, and accepting the fact that we're not going to master it. If we take somebody down to the basketball court and show them how to throw a free throw, we don't expect them to be able to peel off 3 baskets one after the other.
Yeah.
So we have to be accepting that we're going to fail, but this is committed action towards values rather than goals.
Right.
And I'm sure Bronnie would have talked a little bit about that. This is really about just moving towards the values, the things that bring value and meaning and joy to us as individuals every day. And of course, they're different for everybody.
Yeah. And so that's where this sense of purpose is so important as well, presumably.
Absolutely.
Yeah.
It's critical, really.
And do you coach your patients or clients through that? I mean, is that something that is a formalized part of the process?
It can be. Again, we don't have a woe to go process, as in everybody goes through every step.
Yes.
We take people through as many steps as we need in order for them to be able to grasp what's going on and then put it into play for themselves.
Yes.
But yes, for some of the longer term cases, or where people are really struggling to identify what their values are because we get separated from them by pain and anxiety and depression, then yes, there's a formal process that we can do to help people identify, and even in group work can do the same thing, help people identify what their values are and then how they're going to take some action towards meeting those values.
Yes. Okay. Great. Now, I noticed in one of your papers you referenced Daniel Siegel, who I'm a bit of a fan of. I've read several of his books and listened to various audiobooks, and there are a couple of things that I know he talks about that jumped out when you were talking earlier. So one of them, actually, what we were just talking about in terms of he describes the different cortical layers, saying there's 6 cortical layers, and you've got information that can come descending through the top layers, and essentially it's in the middle layers where we make sense of that information, or ascending, coming up from the bottom layers, and so when it's descending through from layer 6 down towards the middle layers, then what that is essentially coming through is our kind of filter of prejudgment, our experience, etc. But when it's coming up from the base, so when it's coming up through layers 1, 2, 3, and reaching that kind of midpoint again, that's more like a kind of beginner's mind, and more like a kind of, I guess, to me, it seems to correlate somewhat with what we're attempting to achieve when we're using mindfulness, is this sense of non-judgment. And is that something that you've
Yes.
thought about, or yeah, I thought you would have done.
Yeah, and I think you summed it up quite well. If we're on automatic pilot, as we talk about, then that descending information can be very judgmental. It's all about my expectations and how this relates to me and my experience, and the ascending information is then processed against that backdrop, and we can come to some quite strange beliefs and perceptions about our existence by doing that. And mindfulness and sort of integration, as Dan would talk about, is really more about choosing and observing without the baggage of my previous experience, to notice exactly what is. I don't necessarily need to be able to overthink this particular sensation or this particular input. And I think this ties in a lot with Stephen Porges's theories of the vagus nerve, and the idea of what he calls neuroception, that the vagus is basically sending information up our gut sensation. And then it's the processing of the brain that turns that into something that potentially we find very stressful.
Right. Yeah. Makes sense. Yeah, and I suppose the other thing that I was thinking of in relation to Dan Siegel's work is he makes the comment. I'm sure he's not the first or the last person to make the comment, but he says the brain is the one thing that can grow itself by thinking about itself. something along those lines. And I was actually listening to a podcast with Dawson Church last week, and he's, I don't know if you've heard of him, but he's written a book called Mind to Matter, and he's got some stats, and these are just from my memory recall, so I might be slightly off, but he was talking about doing a group that did meditation just for 14 minutes, 14 minutes per day. I don't know why 14, but that was the duration. And across an 8-week period, he said they saw growth in various structures within the brain. And unfortunately, my memory is not good enough to remember exactly which structures they were, but they related.
In general, you start to see a little increase in the grey matter. In the
grey matter, right? Yes. Yeah. But he said one of the structures, which in particular is associated with a sense of well-being and happiness, grew by 24% in 8 weeks.
Wow.
And he said, this is just extraordinary. And I'll have to dig that out and put it in the show notes so that people can actually look into it if they're interested. But it just struck me that, I mean, even if those figures were slightly overinflated, that's still incredible that you can grow the brain through thinking in a certain way and using
absolutely. They did some studies at University College in London of London taxi drivers doing the knowledge, and they did some brain scans at the point that they started, and then at the point where they finished the knowledge. It takes them about 3 years, and you could see an increased volume of the hippocampus in the brain, and this is the area that's associated with navigation.
Yes, yeah.
So as they were learning the hippocampus, they were exercising, it was growing. And within reason, the longer somebody carries on driving a London taxi cab, the greater the expansion of this area in the brain is.
Right.
It's we talk about it being a remarkably plastic structure. It evolves and it changes quite literally with every experience that we have, which is why this idea of being careful about what we pay attention to makes so much sense, because if we spend a lot of time paying attention to lots of negative things going on in the environment, or a lot of negative self-referential thinking, well, then we're just growing and strengthening that area of our brain. It makes it easier for us to do it.
Yes. So where do you see... Go on.
I was going to say, it just happens so quickly. If you blindfold somebody so that you take all the light out of their optic nerve, the visual cortex starts being recruited by other areas of the brain within 24 hours. The brain kind of goes, we've got this huge chunk of computing power that's idle, so let's shift it and do something else with it.
Yeah. I was going to ask, where you see your work overlapping with the spiritual kind of side of life, people developing either spiritual philosophies
Sure.
or following spiritual pathways, because much of the advice that has been passed down, that, people talk about wisdom traditions, this kind of thing.
Yeah.
And of course, we know about the religions as well. And we know that there's issues with some religious thought, but that equally there's a lot of wisdom interwoven in there as well.
Sure.
So how do you see your work integrating with that side of things?
I refereed a paper a few months ago where somebody was talking about, the authors were talking about that the biopsychosocial model rather ignored the spiritual aspect of somebody's existence. And I tended to actually disagree, because I don't think that it does. It's about attending to our experience as it is, and that these practices and this work allows us to pay more attention to the things that are meaningful to us. And if that happens to be a spiritual belief, then that's fine. So we'll often say, that these types of practices, if you have very strong spiritual beliefs, will potentially enhance them, not detract from them at all. And I'm very careful to point out that I do this work very much as from a neuroscience pain perspective, not from any other perspective at all. This is all about what the science and the research tells us that we can achieve by utilizing these approaches.
But is there a danger in some people's belief systems? And I guess this is where it could get very controversial, because of course it is by its nature judgmental. But if you've got a belief system that disempowers, and this was the point that I made in the Ghost in the Machine papers that I wrote, was that a lot of our traditional monotheistic religions, of course, place the locus of power outside of the individual to an external authority figure in the sky, that's unseen, and it's quite paternalistic through the storytelling, quite paternalistic and quite forceful, and you could even say vengeant in some of the stories.
Yes. Yeah.
And even though I think many people that have been through the formal education, they could perhaps look at some of those stories and decide for themselves whether or not they sound plausible, whether they sound helpful. There is this kind of underlying current of beliefs that have been passed down across the generations. And this kind of comes back into the whole biopsychosocial thing, is that you've got a whole society. If we were to take the UK as an example, you've got a whole society there that was based on a Christian belief system. And a lot of those values, even though they are not explicitly described as necessarily coming from the Bible, a lot of those values are still present implicitly in our behaviors. And I think there's been quite a lot of research into that, which shows that. And some of them are probably not that helpful to us.
No. And I think, pain science for many years was seen very, very strongly through the lens of Christianity.
Really? Okay. Yeah.
So it's intertwined in all of these things. My kind of view of it from an individual perspective is, and in the pain science, we you can see people discussing the idea that praying, or as you say, putting your belief in a higher power is what's known as a negative coping strategy. But I think it depends how you do it.
Yes. Yeah.
So I generally believe that we have to meet our patients where they are and who they are. And at the moment, and we're a very diverse multicultural society in New Zealand, like you are in the UK now. And I have had the fun of meeting people with strong Muslim and Islamic beliefs, which I really knew nothing about.
Yes.
And we've had some very interesting conversations interweaving this their faith with the work that we do within a pain context. And I've learned a lot and learned to respect their beliefs, but I wouldn't challenge them.
Yes.
It's about trying to make a sensible pathway that is coherent and makes sense for that individual to be able to move forward.
Yes. Because I guess it could be equally as destructive to question their faith, or because essentially then you're questioning, again, on the biopsychosocial level, you could be ostracizing them from their tribe.
Indeed.
Essentially. Yeah.
You're not validating their experience. I think the difficulty can be when people see pain as somehow as a judgment on them. And so that, again, that has to be carefully and culturally considered as part of a biopsychosocial approach, and gently tested where it can be, but not dismissed out of hand.
Yeah. Okay, so I guess linking in with this to some degree is the idea that your work can be preventative, because if you've got the right kind of models in place in your mind, and you can practice this mindfulness, as you say, you engender the neuroplasticity and then the life experiences associated with an altered outlook on life.
Sure.
And so, how much have you attempted to apply this preventively? Because I think in your reports, don't you mention about prehabilitation?
Again, there is some evidence that if you can modify people's beliefs, particularly if they're going towards some kind of orthopedic procedure, and there are a number of factors which are obstacles to their recovery, if you can modify those factors before they have the intervention, then clearly you're going to help them recover afterwards.
Yes.
It's actually much easier to teach people some of these skills if they don't have a backdrop of a lot of life stress or a lot of pain or distress in their life. And that was one of the things that drew me to the Mindfulness in Schools charity in the UK.
Yes.
And there's a very large study going on in the UK at the moment, the Myriad study, where the charity has just taught 3,500 11 to 14-year-olds the 10-week course, and they have another 3,500 acting as the control group. And it's been funded by the Wellcome Foundation, and they're being followed for 7 years.
Right.
And they're looking at outcomes in terms of mental and physical health and well-being, academic achievement, interaction with the criminal justice system. So a whole range of different outcomes. And so what they're essentially looking to see is, so if we teach people these skills in adolescence when the brain is going through this massive rewiring process, can you set them up for different experiences as they move into adulthood?
Yes.
Fascinating.
It is fascinating. It would be very, very kind of interesting to see where that goes and what comes of it. Because there have been some other studies like this which have shown quite incredible, in the real sense of the word. You wouldn't give it credit if someone suggested it to you. Results. And I'll really look forward to hearing more about that. So I guess that's going to be what sort of year would that be? 2025 to 2026?
I think they're going to be publishing the results as they sort of come to hand.
Right.
The pilot study that was published in the British Journal of Psychiatry showed that the pilot group, they particularly looked at their stress levels around the end of year exams, and they found less less stress,
Mm-hmm.
less anxiety, clearly enough to make us say this needs to be looked at,
Right.
over a longer period with a highly powered trial.
Yeah, that's very exciting, isn't it? I
Yeah,
find that really
absolutely
positive.
it is.
Yeah, yeah.
Yeah.
Excellent, excellent. Well, maybe we'll have, if podcasts are still a thing in 6 or 7 years' time, we might have to do another one
We'll come
on
back
the
and do it
results of
again.
that. Yes,
Yeah,
exactly.
that'd be fascinating.
Fantastic. Well, look, Nick, I know it's getting late there for you, so I'll let you head off. But if people want to get hold of you, where's the best place to? I know your site, but do you want to just shout out the URL?
That's it's quite simple. Dr. Nick Penney .com.
Yeah.
Or is it
So it's
drnickpennyphd.com? I don't
Let
look at it very often myself.
me look. I will tell you because I was on it earlier. So yeah, it's Dr. Nick Penny. So
It's
Nick's
Dr. Nick Penney, NickPenney.com.
That's it.
Yeah,
You got the spelling right.
that's good. I've been practicing a lot.
Yes, fantastic. Well, thank you so much for sharing all of this, really fascinating information. I'd love to have gone on for another hour or so. I just was aware that the time was creeping late for you there. So, hopefully our paths will cross. I'm out in New Zealand in March, so who knows? We may get to cross paths then. But
absolutely, look us up. Yeah, that'd be great.
Thanks so much for your time.
You're welcome, Matt.
Cheers, Nick. Bye-bye.
Cheers. Bye-bye.
Well, I think you'll agree, another fascinating series of insights from a master in their field, helping us to identify order from the chaos. And I think what really impressed me the most is that Nick's work really achieves that, not just in his theories, but in the results he gets with his clients, which you can see in the show notes on mattwallden.com. By now, you may have gathered I will be in Nick's stomping ground, Auckland, in March 2020 to explain how mindfulness, the biopsychosocial approach, and many other modern clinical modalities can be contextualized and prioritized by being placed into a larger evolutionary model. As John Holland says, a good model repays decades of research and provides accurate predictions into the indefinite future. So that's what I'll be presenting, hoping to contribute my 2 penneth worth to help move us from chaos towards order. Bye for now. See you at the next show.